Hi, I'm Christie Ballantyne. I'm here with Deepak Bhatt. He is the director of the Mount Sinai Heart Hospital. We're in Boston at CMHC. Deepak, a lot going on in terms of thrombosis, coronary disease, and also some pretty interesting things about AI that we're futuristically moving into.
Right.
Give us some highlights about this morning.
Yeah, absolutely. So thrombosis remains an important and hot topic in cardiovascular medicine. I did review some data that looked at a trial of atrial fibrillation patients with stable coronary artery disease. Should they just be on an oral anticoagulant, a DOAC or NOAC, or should they be on that plus an antiplatelet agent? And what the study showed was that if it's stable CAD and AFib, and oral anticoagulant alone is enough. Don't add on an antiplatelet therapy. At least don't do it routinely. It raises bleeding risk and doesn't seem to reduce the risk of ischemic or thromboembolic complications. So that's an important message. There are still some ongoing trials on the topic, but for now, AFib, stable coronary artery disease, just go with the anticoagulant appropriately dosed. Now, if someone got a recent stent, if they had a recent acute coronary syndrome, that's different. I'm talking about stable CAD plus AFib. So that was one trial in the thrombosis space. Another thing I mentioned was a meta-analysis, the Panther meta-analysis that pulled a bunch of different trials comparing antiplatelet therapy regimens of monotherapy, largely clopidogrel or ticagrelor monotherapy versus aspirin monotherapy, finding that the ADP receptor antagonists, that is clopidogrel or ticagrelor as monotherapy, were better than aspirin as monotherapy, lower rate of ischemic events, and not an increase in bleeding. So for secondary prevention, particular high-risk secondary prevention, perhaps we should, and the data show can do better than aspirin alone.
Those are really important points for clinical practice in terms of the first one, maybe less is more. And the second one in terms of optimal treatment. Now that we have generic clopidogrel, this should be moving up, and I think in terms of our considerations.
Agreed.
Some interesting things on Revasc too.
Oh, absolutely. There have been a lot of trials that have come out in the past year that have to do with revascularization. You know, one interesting trial was actually a sham control trial of PCI, percutaneous coronary intervention, versus sham for stable angina for symptom relief. Now that might seem like kind of an obvious thing. A lot of people would assume that PCI is good for angina. Indeed, that's what interventional cardiologists spend a lot of the day treating. But there were some skeptics out there and said, well, maybe some of it's a placebo effect. You get a procedure and you think, oh, I feel better. Of course, pain, there's always a subjective component to it. But this trial established absolutely conclusively that PCI is better than sham control for symptom relief. So a big win for interventional cardiology for anyone that was skeptical of the value of stents in stable angina for symptoms. Other trials came out looking at that age-old question of someone comes in with a myocardial infarction. Of course, you stent that culprit lesion, that is, if they come in with an anterior MI, stent the LAD. But what if they have a severe lesion in the right coronary artery or the left circumflex or both? Should those also be stented? And the jury is in. Really, complete revascularization is the way to go, probably before the patient is discharged from the hospital. So yeah, the night they come in, Saturday night, go ahead and stent that LAD, but then before they leave the hospital, go ahead and take care of the RCA and circumflex. Some data even suggest maybe even better to do it during that initial procedure. That's a bit more controversial, but certainly I'd say, barring contraindications, do it while they're in the hospital, complete the revasc.
You know, and you finished up with a really hot area. We're seeing more and more people who want CTA, not for chest pain evaluation, but in terms of how much disease do they have. And then with the tools that are happening with AI, ways of analyzing this, tell us. You mentioned a very fascinating study that you're helping lead. Tell us a bit more about this.
Sure, it was a TRANSFORM trial that I mentioned, and this is a randomized trial, about 7,500 patients or so, primary prevention, randomized to either guideline-based care, that's the control arm, do whatever the guidelines say for primary prevention, and in the investigational arm, the patients are getting a CT angiogram, a coronary CT angiogram, non-invasively at baseline and at 2 years, and then the plaque is staged, and if they've got stage 1, stage 2, stage 3 plaque, that will help us titrate the intensity of the medical therapy going beyond what the guidelines would actually recommend that they get. And the idea then is to see, A, can we classify patients better in terms of risk than, say, the ACCHA risk calculators? B, can we influence the progression of plaque between time 0 and year 2 with more intense therapy than the guidelines recommend? And 3, this is the most ambitious goal of it, is to see can we actually reduce cardiovascular events with an approach of more intense medical therapy titrated and guided by what we see on the coronary CT angio.
So really looking at the concept of precision medicine, that using new analytical tools and better imaging modalities, can we actually precisely match the treatment to the amount of atherosclerosis?
Exactly,
So
and using AI to help with that assessment. That is, there have now been millions of images obtained of coronary CT angiogram of different people. Some of those folks, you track what their event rates are. So once you're able to feed all that into an AI engine, you can figure out, oh, okay, you've got these characteristics. They're similar to the million other images where some of those people had heart attacks, and try to figure out, okay, this person really is at increased risk of heart attack. And it's an approach to try to personalize medicine. Of course, all this needs to be validated in a randomized clinical trial, but maybe a glimpse of what the future holds for detecting heart attacks before they happen.
Well, really a lot of information packed in this morning, very exciting, and as always, so great for you to cover so much in such a short period of time.
Yeah, well, that's one great thing about the CMHC meeting. It's really action-packed, it's information-packed, but in a way that I think is digestible and fun for the audience.
All right, thanks, Deepak.
Thank you.